Welcome to the Health and Government. Good morning. Welcome to the Health and Government Operations Committee. This is the Public Health and Minority Disparity Subcommittee. We have quite a few bills today. We're going to start with Senate Bill 565, and Aaron Hopwood, who is the counsel for the subcommittee, will explain each bill we have, and then we'll let the stakeholders speak, and then we'll open it up for discussion. Thank you. Aaron, good morning.
Good morning. Senate Bill 565 is the cross-file to House Bill 309, which was passed by HGO. In the Senate, there were two similar Senate bills touching on the issue that Senate Bill 565 addressed. That was Senate Bill 565 and Senate Bill 796. The bills are so similar that the thought here is to amend on the provisions of Senate Bill 796 onto 565. So you see in your reprint on page 4, after line 23, this is the new language that would be added to 565 that is transferred from 796. And this would require the Healthcare Disparities Report Card to include a comparison of certain information that's included in prior report cards. And then also moving on to page 6, there is study language that require the Office of Minority Health and Health Disparities in coordination with the Healthcare Commission and the Department of Health to submit to the General Assembly a plan that reflects the state's current goals and implementations to eliminate minority health disparities. So the idea would be to amend the 796 onto 565, and then House Bill 309, which is an EHE, that committee would make the same changes to the cross-file of 565.
And for the members, this was Senator Becker's bill. Did she testify? And we put it in the bill. The Senate is aware. Aaron has communicated with the President's office and with counsel from the EHE committee. And
Senator Eckert was fine with it. She just requested that she be added as a sponsor, and that's reflected in this amendment as well.
Thank you very much, Aaron, for doing all that work. Members, are there actually any stakeholders that want to be heard on this? If you will be so kind, and under the participant, there's a little icon for raise the hand. That's how we will operate this meeting. If you could raise your hand, please. Seeing none, any other members have any questions or concerns on the bill? Any questions for Aaron? Seeing none, may I have a motion on the amendment, please?
Move the amendment.
Move the amendment. Second.
Oh, second.
It's been moved and second. Any questions or concerns regarding the amendment? I don't see any questions or concerns on the amendment. All those in favor say aye.
Aye.
Any opposed? Seeing none, on the bill as amended, may I have a motion?
Move the bill as amended.
May I have a second?
Second.
It's been moved and second. Any questions or concerns regarding the bill as amended? Seeing none, all those in favor say aye.
Aye.
Any opposed? The bill passes as amended. Thank you, Aaron. Aaron, will you be so kind and go to the next one? Senator Alfred is here. If we could do her bill, which is Senate Bill 777.
Senate Bill 777 renames the Maryland Prenatal and Infant Care Coordination Services Grant Program Fund to be the Maryland Prenatal and Infant Care Grant Program Fund, and it expands the fund's purpose to include awarding grants to federally qualified health centers, hospitals, and providers of prenatal care. The bill would increase the amount of funding the governor must provide for the fund in the annual budget from $100,000 to $1.1 million in fiscal 2023, $2.1 million in fiscal 2024, and $3.1 million beginning in fiscal 2025. This funding must be used for grants to FQHCs, hospitals, and providers of prenatal care. And beginning in calendar 2023, the Secretary of Health will be required to submit an annual report by December 1st to the Governor and General Assembly on the grantees and the programs that were awarded under the bill.
Good morning, Senator. Can you please tell us why we need this bill?
Good morning. Thank you so much, Madam Chair, members of the committee. For the record, Senator Sarah Elfreth. I represent District 30 in Anne Arundel County. This bill has come up this issue has come up a couple of times. About 2 years ago, doctors from Anne Arundel Medical Center came to my office, literally in tears, because women were presenting at the emergency department ready to give birth and having never received a single prenatal care visit, and the chaos that causes when women don't know the situation, that the providers don't know what could possibly go wrong, has incredibly harmful consequences that this committee knows very well when very basic preventative care is not provided, particularly for mothers. And so the wonderful work of a work group over the last year presented a report in August on how to increase maternal and child health care. This bill is recommendation 6 of that, which talked about the need to provide prenatal care up front. About 7% of Maryland women never receive a prenatal care visit. And we all know the consequences of what happens when babies are born underweight and the long-term health impacts that can provide. So we put this bill together. It's also a recommendation of the Senate President's Work Group on Equity and Inclusion. We worked with the hospitals, we worked with MedCai, we worked with a lot of the providers to make sure that this is in a good place to provide these grants to FQHCs, hospitals, providers to provide prenatal care for women who otherwise don't have it, who are underinsured or uninsured, so that we can get to this issue, really attack it from the beginning. This committee knows we have alarmingly high rates of maternal and infant mortality in the state of Maryland, particularly for women of color. This bill will help us. It's not a silver bullet, but will help us bring those numbers down. And it's about healthy moms, healthy pregnancies, and healthy babies. Thank you, Madam Chair.
My pleasure. Any stakeholders for this bill? Can raise your hand for it. I have Delegate Hill has a question.
Yes, thank you, Madam Chair, and thank you, Senator Elfreth, for this legislation. Can you just comment that change in the funding amount, and if any of that funding we're expecting to come through from federal money coming now, and also we just extended appropriately coverage for mothers to a year on Medicaid. Is there any overlap? I mean, I want to get a sense of what we're trying to do overall and where the funding comes from.
Absolutely, Delegate. So I'll take your second part first. Senator Washington has been working on that, and the governor provided funding, as you know, in the supplemental for extending postpartum care for women on Medicaid. That was also a piece of the report that we received in August. It had about 9 recommendations that are all very solid recommendations. These 2 are part of that report, so I look at them as working in tandem. In terms of the funding, the bill doesn't specify federal funding, but I would hope that this federal administration would also take this as a priority and start providing more funding to the states. But I envision this to work as, here in my home county, Anne Arundel Medical Center, would love to stand up more clinics in communities that, for whatever reason, be they underinsured or have transportation challenges, to provide this direct preventative care to women, meet them where they are to provide the care.
We have a question. We have Pam Casemeyer, then Robert Elliott. Ms. Casemeyer.
And so also Delegate Hill, maybe to weigh in, at least from our perspective, it's a grant program, and it's really designed to begin to address the uninsured, those who wouldn't even qualify for the Medicaid expansion that you did, because they don't qualify for Medicaid necessarily to begin with, or they're underinsured. But it's a grant program really to begin to gather data to understand if there's a way to establish a more robust permanent program that's broader, rather than jump in before we get that information. So it's a small amount of funding, a very focused grant program to begin to build that platform, so there's good data and justification for how we long-term address this need for prenatal care.
Thank you. Ms. Elliott.
Good morning. Thank you. Robin Elliott here today on behalf of nurses, nurse midwives, community health centers, and the Maryland Dental Action Coalition. Wanted to thank Senator Elfreth very much for recognizing in the bill before you, it is making sure that individuals get prenatal care. And that prenatal care could include behavioral health and oral health. And as you all hear so many times, both of those types of services are really part of the equation to making sure someone can maintain a healthy pregnancy. And so we're very excited about this bill, and we really see this as a companion bill to Senate Bill 923, which you all, I think it was just yesterday, it was on the floor, which extends postpartum coverage. Both bills are really important to get at Maryland's underlying maternal morbidity and mortality issues. Thank you.
Are there any questions from the committee members? Seeing none.
Move the bill.
May I have it's been moved. May I have a second, please?
Second.
All those in favor say aye.
Aye.
Any opposed? Seeing none. We have the companion bill, members, and it is House Bill 1349, Delegate Semple Hughes. Erin, how do you propose we address this?
I think you could just vote on both bills at the same time.
All right, so may we vote on both bills at the same time? May I have a motion on both bills? Let's do it again.
Move both bills at the same time.
Second.
Second, it's been moved in second. Any questions on both bills? Seeing none, all those in favor say aye.
Aye.
Seeing none, it passes unanimous. Thank you, members. Thank you, Senator. Thank you, Al.
Thank you.
My pleasure. Erin, will you be so kind? And let's go on to Senate Bill 67.
Senate Bill 67 is an emergency departmental bill that authorizes a paramedic to administer a vaccination included in the Centers for Disease Control and Prevention's recommended adult immunization schedule or authorized for emergency use by the U.S. Food and Drug Administration, and also for tuberculin skin testing. The services must be part of a public safety or commercial emergency medical services occupational health program or a population health outreach effort conducted by the appropriate local health department or a hospital or health system in the state. The bill would terminate July 1st, 2024.
Thank you so much, Erin. I appreciate giving a summary of what it does. So today with us, we have great expertise, which I am so happy to see my colleagues, Delegate Kipke, Delegate Kelly, Delegate Collison, because this bill kind of, it's related to all these other committees. So I welcome their expertise. So before we open it to them and to the members, Pat Gaynor, will you be so kind and tell us, as Delegate Chris will say, why is the bill needed?
Thank you, Chair Penumelik. My name is Pat Gaynor. I'm the Deputy Director at the Maryland Institute for EMS Systems. We're an independent state agency. We oversee EMS in Maryland, license EMS providers, designate hospital trauma centers and specialty care centers. This bill is important because it updates a 20-year-old statute that was passed in 2000 that permitted EMS to conduct occupational health efforts in their own fire departments for flu vaccine and hepatitis B. It did not, however, allow for other vaccinations that might be needed. It did not include commercial services, the businesses, the ProCare and Butler Transport, the kind of ambulance services that transport patients between hospitals to higher levels of care. They were not allowed in this bill for some reason 20-some years ago. So this bill would update that to allow EMS occupational health efforts within their own programs. What sort of vaccines might be needed? Tetanus, for example. EMS providers often suffer an injury because of a accidental needle stick or an accident that they suffer when they're rendering care. They get cut. They should be able to get a tetanus shot within their own department without having to take time off to go to their doctor. And EMS paramedics should be able to give those shots. Those occupational health efforts have to be approved by MIMS, and they have to be under a memorandum with the county health department according to our protocols. So what the bill does, it expands it to allow EMS to give vaccines that are approved by the CDC or the FDA under an emergency use authorization. And secondly, the bill would allow county health departments and hospitals that are conducting public health efforts to reach out to EMS services and have those EMS paramedics assist them in their public health efforts by giving shots. And this has been most dramatically illustrated by the COVID effort that has put us all sort of in a new way of doing business. We have 18 jurisdictions who have agreements with their county or city health departments to have paramedics help with the vaccination clinics. The paramedics don't decide who gets vaccinated. They don't decide what vaccine is given. They are literally the shot givers. This would allow the county health departments and the hospitals to use EMS in these kinds of public health outreach. It would be only paramedics. It doesn't go to any other level of EMS provider. Paramedics are the highest level trained providers. They are trained to give vaccines. 34 states allow EMS to give vaccines. Maryland has been behind the curve on this. And that's kind of it in a nutshell.
Delegate Lewis, will you be so kind and mute yourself? Delegate Lewis. Okay, I am going to open it up for questions from the members, and I particularly would love to hear from my expert members as well. I have Delegate Johnson that has a question.
Thank you, Madam Chair.
My pleasure.
My question for whoever is best to answer, does EMS have access to CRISP to see what other medications folks are on before they give vaccines?
EMS currently has limited access to CRISP. Eventually, they will have more access, but we have connected the EMS medical record with the CRISP into the hospital medical record. But again, EMS only gives vaccines to people identified by physicians and public health departments or hospitals who need vaccines. EMS does not make the decision as to who gets what vaccine. EMS is literally the shot giver.
Okay, thank you. Thank you, Madam Chair.
Thank you for the question. Delegate Kipke.
Thank you, Madam Chairman. I guess it's more of a comment. My thought is, it makes perfect sense to me that this would take place for the COVID shots, wherever the counties could utilize EMS folks to do this. Going beyond that, this is the first time we've seen a bill like this. There's no prior introductions. I don't think we should rush to do this. We should do it if it's going to happen. We should do it very methodically. And I do see that there's some testimony asking for different types of amendments and things like that. So, my preference would be to say, okay, yeah, it makes sense with the COVID because of what we're experiencing, with some type of sunset on that, and then maybe to take a deeper dive into this either in the interim or at some future point. Thank you.
Thank you. Any other questions? I have Deb Ripken.
Morning. I just wanted to, while I think I totally agree with what Delegate Kipke just said, and Pat, based on the goals of this bill that you've described, it's really important. But there is an insurance component that I don't think anyone has really potentially thought about, because the bill doesn't have any impact. You see, there's nothing in the insurance code in the bill. And so I just want for you all to think about, not all EMS providers contract with all carriers. And so while they are the shot givers, they are still going to be reimbursed for the service. And if they are going to see a member of a carrier and they have not agreed as their fire department or as their EMS department to participate in that network, that member will be balance billed, or pay higher amounts than if they would if they had gone in network to a provider. One thing that is important to know is COVID vaccines, there would be no balance bill.
It's also in
So
health
that one,
protocol.
because the federal government requires that there is
One
no
second,
payment.
please. 1 second. Delegate Lewis, can you be so kind and mute yourself? Delegate Robin Lewis. Delegate Lewis. Delegate Robin Lewis. Thank you. Go ahead.
So for COVID, it is correct for a COVID vaccine that no one would have to pay anything, regardless if you're in or out of network, because the federal government actually will pay for the vaccination, and for the administration, carriers pay for that, and that is agnostic in or out of network. So the member would be not have to pay anything. So from a insurance perspective, that does not, to me, create a problem if this bill were limited. I know that's not the goal, but I just need you all to really consider the fact that there will be issues with if someone doesn't know that the EMS provider that's coming to give them a shot is not in their network, they're going to be paying for that shot. And most vaccines that are delivered in network are free. There's zero cost share on that, because that under the ACA is considered a preventative service. And so not all plans, but because I think the grandfather plans are not do not apply, but for most plans, for traditional vaccinations that are preventative services, there is no cost share unless you go out of network, and then there is a cost share. So I just wanted to raise that with everyone.
Great. And I have next Delegate Kelly, followed by Pat Gaynor, followed by Robin Elliott.
Thank you. And I'm just looking for a little bit of clarification, somewhat following up on what Deb just said. In terms of for COVID vaccination, do we need this bill, or is this authority already exist under the governor's emergency order? I'm pretty sure that the definition of shot giver is widely expanded right now. And I would imagine that EMS can already give the COVID vaccine without this bill for the foreseeable future. Is that right? That's my understanding?
My understanding, and I can be corrected, is that under the governor's emergency order, they're covered during the duration of the emergency order. Can someone correct me if I'm wrong? Pat, am I right?
That's correct. And our concern is that I don't know when the governor's order is going to go away. It could go away in a month, it could go away in a year, but once it goes away, we are back to the constraints of a statute that was passed in 2000, and EMS will not be able to participate in vaccination efforts. And we foresee the COVID vaccine follow-up going on a long time. It's going to be a long time to roll this out. And you know, I know COVID is an unusual situation, but we have in the EMS world have had concerns with outbreaks of measles in certain geographic areas. And that's important for us to be able to vaccinate our own folks for that. And if it's part of the county health response to a measles outbreak, right, EMS should be able to help. And if I might, just to respond to Deb's points, which are good points, but let me remind you that these EMS would only be part of a hospital outreach or a county or city health department outreach. EMS is not going to be billing for that. The hospital might be. The health department is authorized to bill, but EMS is not going to be sending the patient a bill. EMS is there to help.
It sounds to me, if I may follow up, Madam Chair, is that okay?
Absolutely.
Thank you. Just to clarify my question. So if we think that COVID is covered for the duration of the emergency, although it may be necessary for longer than the emergency, we may pursue something like what Delegate Kipke suggested, which is giving us some assurance, for some period of time that COVID would be allowed to be covered, but not necessarily rushing to this broader policy expansion. And until next session would be my thought. Maybe modify the bill so that we're just doing it for a period of time. But my question, I guess, is outside of COVID. Then it sounds like what we're talking about is vaccinating the occupational health efforts that you were talking about, vaccinating your own folks, which I would assume payment is covered for. That's part of the calculation, figuring out whether it's efficient to do that. Is that right?
That's correct. And right now, commercial services can't do that. EMS is limited to influenza and hepatitis B. They can't do hepatitis A. They can't, none of it. So, yeah.
So, and then in addition to those occupational health efforts, there's this sort of broader expansion into supporting public health efforts, which we're seeing happening on the ground right now, and we know is useful. So we probably want to find a way to do it, would be my guess. But I'm not sure that we need to rush into making a permanent decision right now this session on that. So again, I go back to sort of Delegate Kipke's suggestion of making sure we hold things in place as they are and potentially work out the kinks as to how to best expand it over the interim.
Thank you, Delegate Kelly. We'll have Ms. Robin Elliott, followed by Erin Dorian, followed by Delegate Hill.
Good morning, Robin Elliott. This morning, I'm wearing the hat of the Maryland Nurses Association in support of this legislation, and I wanted to share why. So this certainly COVID is a big concern right now, but the nurses have been really focused on gaps in vaccinations that may be exacerbated by COVID. So whether it's measles or some other type of potential outbreak. And we really see paramedics as the surge capacity that we need to build in that infrastructure, that public health infrastructure, to be able to flex to meet emergent public health needs. And because of the way MEMS is structured and the way this bill is structured, we see this as highly driven by protocols, where all the sort of questions around insurance and how it's going to be delivered will be highly thought out for each circumstance with either the hospital partner or the local health department. And so we're really very much in support and look forward to working with the committee and Pat, of course, to determine how to best roll this out. Thank you.
Thank you. We have Ms. Dorian, followed by Delegate Hill.
Thank you, Madam Chair. And many of the other speakers just said what I was going to say, especially Robin. I want to share with you the Hospital Association's strong support for this legislation and for, what MIMS is really trying to do here. We thought that this was really well thought out and thought through, and where we're really interested is that second piece of the bill around allowing for public health outreach programs for hospitals and for local health departments, although I don't speak for them, but we do know that MACO was supportive of this bill. The limiting factor usually is that the shot giver. There are not that human capital be able to give the vaccine. For the past couple of months, we've been dealing with limited vaccine supply, and now we're for the COVID pandemic, and now we're moving into a time where we may not have enough vaccinators to really keep up with the demand for the COVID vaccine. Beyond the COVID vaccine, we know that in communities there is a lot of issues around accessing the healthcare system. And for some communities, the paramedics, EMS are their entry point. They don't have a primary care physician. They don't even have a pharmacy. So being able to go into those communities and run these public health vaccination clinics with the support of the paramedics will allow hospitals and local health departments to scale up vaccine clinics for things beyond COVID, for the flu, for measles, for whatever that community might need. And so that's the one thing that I don't think we heard today, is that this will really help get into communities where the trusted healthcare provider are the paramedics, where the only entry point to the healthcare system may be the EMS system. And so we want to be able to use those trusted providers as part of these public health vaccination efforts. And, I really, I appreciate what Ms. Rifkin said earlier, and we'd be willing to sit down and work with her to think through some solutions so we can make sure, her issues are addressed. But we think that this is a really important piece of legislation.
Thank you. We have Delegate Hill, followed by Delegate Collison.
Thank you, Madam Chair. So first, we've done so much to try and increase vaccinations through pharmacists, which I have to say, I've had a lot more problem with that extension than I do with the EMS extension. And I'm looking that this is, again, they've already been at least authorized to do influenza and hepatitis B, recognizing, Delegate Kipke's point and Ms. Rifkin's concerns. I think that they're not particularly well placed. So I have two questions. For Ms. Rifkin, I'd like to know right now when EMS has an extension of the hospitals or an extension of the public health, when they're providing influenza, hepatitis B, and TB skin testing, how is that being handled on a billing basis? I would suspect it's not a problem, but I'd like to know. And then a question for Ms. Gaynor.
So I don't know, but I also will tell you, I don't believe this bill says what if that's really the goal and the role that says that an EMS service, ambulance service, medical, whatever this EMS paramedic may not bill a member for the administration of the shot or for the actual vaccine, and that it only can come from a hospital or a health department. That doesn't say, I don't see that it says this here. And so if
you saw that amendment, you'd be happier with the bill.
All I'm trying to do, I think that there's merit to the bill. I'm trying to let you know that I don't think that there's an insurance component. We will bill the way we have to bill, but as citizens in the state of Maryland, they're going to potentially think that they're getting a service that they would normally get under their insurance policy. And if that ambulance company, EMS service, is not contracted with us, this bill does not tighten that up enough. And I just think you need to think about that, because there are a number of these services that are free with zero cost share, with no balance bill, with no deductible when they stay in network. And it's an outgrowth of this. It's not necessarily the goal, what the bill was trying to do, but I think it's something that is an unintended consequence that the bill should, I suggest, tighten it up or narrow the bill in some way to make sure that those issues of what members will pay and what insurers will be responsible for are not falling outside of what you thought the bill was going to do.
Thank you. And Ms. Gaynor, first that point. So I'm looking here on page 2 under authorized by the Institute. It says part of a public health safety or commercial EMS service occupational health program. So I think the points that were just raised are good ones. And so question about how we tighten that up, but also my original question for you was going to be, how do these programs work now? And how are you envisioning it? Because I do think this is an opportunity, you all have seen it as an opportunity to use the need for COVID vaccinators to sort of jump out and do this thing you've been thinking about for a long time. And as Delegate Kippy says, we haven't seen much legislation proposed on. So if you're seeing this as a leapfrog expansion, how do you envision these being done? And how does this not take away from EMS's normal responsibilities?
Well, I would look to the public safety jurisdictions who do currently the occupational health programs and do the influenza and hepatitis B inoculations. And that would be the model. And as there's the statute that says here's what they can do. And then we have our protocol book. EMS operates under protocol. They have no independent decision-making capability in the field. Our protocol book defines how these vaccination programs are to roll out. There are a number of steps. There has to be an agreement with the local health department. The medical director has to be on board. There's an infection control program. There's an immunization record form. It's all laid out there. to expand it to the commercial services, who really should not have been left out in the beginning, and I can't tell you why they were, would just require that change to of the statute, the terminology, to bring them into the fold so they could have that same, set up those same programs, to do those same inoculations.
But I haven't seen, I don't know how these programs work. I've never seen EMS doing this. So I'm just asking, how does it work now? Do they set up a tent? Do they do a regular EMS call and they say, oh, by the way, have you had a tetanus shot? I don't understand how they're working now and how that would change.
Right, the occupational health program is just, imagine it happening in the fire department. The fire department says, in the firehouse, we are giving flu shots from Tuesday to Saturday to our EMS folks. Everybody, paramedics, EMT, whatever, if you haven't had a flu shot, come in and get your flu shot. And that would work the same way for the commercial services then.
So they would be sponsoring, but not just for their own, they would be sponsoring it for the community.
No, it would just be for their own. But if a hospital or a public health department wants to do flu shots and wants those to be out in the community, they could have the option under this bill of calling up an EMS and saying, would you guys come and help us give the shots in our community clinic? EMS would not do this absent the public health department or the hospital. They would not show up on a 911 call and say, by the way, have you had your flu shot? Let me give you a flu shot now. That's not what's contemplated under this bill. The interaction with the public on the vaccines is through a county health department or a hospital or hospital system.
All right.
All right, thank you very much. Delegate Collison will have the last question.
Thank you, Madam Chair, and thank you for inviting me today. I'm usually the first person who's going to be an advocate for expanded access. But this bill, let's put COVID aside completely. And I have some anxiety over moving too fast on this bill. I think some important issues have been raised around the connection. I remember when we talk about vaccines and the being done at the pharmacy, all the different connections we needed to make in order to make that happen and people be more comfortable with it. We're not talking about that in this bill yet. I think what I would, and then of course the insurance issue is part of it. And then, even Delegate Hill raised, it's just how it operationalizes what it looks like. So, Madam Chairman, I would, advocate that we stick with COVID, and because that's an emergency situation, and see this bill like sunset around in 2022. And in the meantime, take some time to develop the protocols and processes that the EMS could use in order to become a comfortable access point for all the vaccinations. Because I think the potential is there, but I think we haven't worked through the details. So that would be my suggestion, Madam Chair.
Thank you. Well, I appreciate, I don't know if, I know the chairman is in the meeting. I don't know, Chairman, if you would like to be heard before I speak.
Here I come. I am in the meeting because this is late in the session and I wanted to make sure that I was up to speed with everyone in the subcommittee. And I really appreciate the work that the chairman of the subcommittee has done and everyone else looking at this bill. It did seem to me that it was more complex than it appeared to be, that there were too many pieces. I think we do need to pass a bill. I think that I'm comfortable giving it a few hours and putting it in the committee after we look at it with some changes, or if you want to make the changes that were talked about. I think we need a 1 year as was said, sunset sort of the end of 22 for COVID. I think that makes sense. We have a crisis. We want to make sure we're protecting citizens as best we can. But I don't think we want to open the gate for everyone and everything at this time. So I was really pleased to hear what my members contributed on this subject. Thank you for that. So however the chairman wants to proceed, whether you want to do it now or whether you want to take a few minutes to work on it after the meeting and just put it in the committee voting session later today with those kinds of amendments on it, that I would bow to your decision.
Thank you, Chairman. I really appreciate the courtesy, and I want to thank all the members for what you just, contributed and the stakeholders. So this is what I propose, that Pat Gaynor work with Aaron while we're on the floor on with guardrails to what you heard today regarding continuing the vaccination for COVID, regardless of, till like end of 2022. Because it is important. And then I will suggest, Chairman is amazing in getting people to do these unofficial work groups, that in the summer, there's a work group with everyone that was on here today to try to look at the 34 other states that allow this, to see what does that law look like, compare it to this bill, and then maybe have some discussion in another bill next session. So Erin, would that be okay with you?
Yes, I'll touch base with Pat today.
Pat, will you make yourself available?
Absolutely. Thank you very much.
And if any of you that were here today would like to touch base with Erin, that will be wonderful, okay? And then we'll have, as the chairman suggested, we'll have the bill in the full committee. Thank you so much for your time. We really appreciate you. We do have one more bill, and that we have is actually Senate.
May I interrupt for one more thing? As a kindness for you, I just want to say, since you're right here with me, the voting session will be about an hour after session today, so you can plan your schedules accordingly. I think that will help. It's too bad I can't say that to everyone on the committee, but maybe we can send a text to Melissa. From Melissa.
Thank you so much. Thank you, Chairman. And thank you for being here this morning. And thank you all for your expertise. So we're on to the last bill, and it's Senate Bill 299. Erin, will you tell us why we have this bill here today? I know we have had it before, and tell us what the history is behind it.
Well, the House, you had a bill hearing on the House cross-file that is still in possession of the committee. There's not been action on the House cross-file. You do have possession of the Senate bill, which is Senate Bill 299, which came out of the Senate and establishes the Commission on Trauma-Informed Care as an independent commission in the Department of Human Services to coordinate a statewide initiative to prioritize the trauma-responsive and trauma-informed delivery of state services that affect children, youth, families, and older adults. The Governor's Office of Crime Prevention, Youth, and Victim Services will provide staff to the commission. The commission, in consultation with specified entities, is required to study and implement an Adverse Childhood Experiences Aware program. And the bill requires each commission member to participate in trauma-informed care training, and each specified agency head to designate 2 staff members to carry out certain responsibilities. And the bill would take effect July 1st, 2021. If Delegate Panamonic, did you want me to talk about the ACE work group that
yes, please.
The subcommittee did pass, and the committee passed Delegate Queen's bill on the Adverse Childhood Experiences work group. That was jointly assigned to Ways and Means, and Ways and Means, I believe, chose not to vote on that bill. So it's still in Ways and Means, and this was a companion to that bill. This committee chose not to move the trauma-informed care bill because of the ACE work group bill, but that is currently in Ways and Means and not moving. But you do have possession of the Senate bill, which passed the Senate.
And this bill is a priority of the Senate President. So the fiscal know it's not an issue. It's really an important issue. And Delegate Robin Lewis has done some work and homework. I tasked her last night with preparing so she can address us. So Delegate Robin Lewis, we don't have a lot of time. If you could go ahead quickly and let us know.
Yes, ma'am. Yes, ma'am. Thank you, Madam Chair. Thank you, esteemed colleagues. What I'd like to bring to your attention as we contemplate the Senate bill on trauma-informed care, the Maryland Healing Trauma Act, is that we're not relitigating what trauma-informed care is. This is not a debate about whether trauma exists or whether or not the state should act to address it. We have already in Maryland enshrined attention to trauma-informed care in the education article. In fact, section 7-427.1 of the education article says that the state is committed to develop guidelines to address trauma-informed care in our schools. And in addition, in 2020, the General Assembly passed a bill, House Bill 277, that sets up a trauma-informed schools pilot project. We voted for that. We've already agreed trauma-informed care is something we should attend to. In addition to the education article, trauma-informed care is enshrined in the Health General. In section 10-701, it defines trauma-informed care and says the state has a duty to address it. What Senate Bill 299 does, it sets up a way to implement the state's duty to address trauma-informed care. It designs a commission made up of members of all the relevant agencies, staffed by the governor's office of crime prevention, youth, and et cetera, et cetera. It's got a very long acronym, but their staffing is there. The fiscal note is very minor, about $61,000 in fiscal 22, just to cover staffing and admin. But the commission itself would enable the state to pull together all of these threads, you know, our commitment in the health article, our commitment in the education article, this pilot project we all voted to implement last year. Not only that, by creating this commission, we actually strengthen the promises that we made in passing the state's blueprint for education reform. I think I could even add, you know, in the face of COVID, this trauma-informed care commission that we would set up will strengthen our COVID response. It will further strengthen our police reform initiatives by infusing attention to human mental health in everything that the state does. So I urge your favorable support of Senate Bill 299, not because I'm the House crossfile, but because this bill, once passed, will allow us to deliver on so many of the promises that we've made.
Thank you. Thank you. We have Emily Berg from the Maryland Department of Health who raised. Emily? Ms. Berg.
Hi, good morning.
Yes.
Good morning, everyone. I just wanted to speak today on behalf of the Health Department and say that we at the Health Department and the Behavioral Health Administration have already done a lot of work around this trauma-informed care. Specifically, we have a lot of ACEs projects going on, and we have behavioral health integration, pediatric primary care. I just wanted to say that while we understand and appreciate that this is a very important topic, as we have a lot of initiatives related to this going on, that we understand that the work group would be convened during this time, that many of our staff and resources are devoted to the pandemic public health emergency COVID response. And so that if the committee is working towards moving forward, which we understand that you are, we put in a letter of information on it. So if you all could just reference that in your decision making on this bill today. Thank you.
And I'd like to say, Ms. Berg, that we have put money for staffing in the fiscal note because we're very much aware of that. So the bill will not pass without the money.
Thank you so much.
All right. Any questions or concerns? Seeing none, may I have a motion, please?
Delegate Panamanic, just if you want to extend the same courtesy that you did on Senate Bill 777, if you also want to
on both bills,
just a vote on House Bill 548 as well. We'll
beautiful.
Move both bills.
Both bills have they've been second. All those in favor say aye. Any opposition?
Aye.
Seeing none, the bill passes unanimous, and that completes the work of our committee. Thank you for being so flexible. I'm really grateful. Have a blessed morning, okay? Thank you to the stakeholders. Thank you, Erin. Thank you, Edith.